patient who presented with dysphagia. So I saw this patient for the first time. So we can go ahead and get, oh, it's recording, I think. So the patient presented with dysphagia. I was on service today, so that day, so I did the upper GI. And this is what we see. Any thoughts?
It's a cancer or some sort of mass in the distally.
Okay. So that's what I said. There's this, mass there. So then they went ahead and got, well, they scoped her and then also got chest, abdomen, pelvis. So here's the CT chest. So here, there it is. There it is.
Oh my God.
What do you guys think?
Tumor? Maybe.
Yeah, it looks like linitis plastic almost.
It may give you the abdomen pelvis just a sec. Okay, so let me go up and then come back down. So here it is. So here's, for the students that are logging on, a mass. And there's thickening of the cardia. And then there's the rest of the stomach. And then there's coronals here. Okay. So there's two people who text stuff in. I'm not looking at the text, but okay, great. These are the students. Okay, so we think it's linitis plastica. Was that what the agreement was, or?
It's very infiltrative. Could it be some sort of infiltrative lymphoma?
Lymphoma. Okay. Any other DDX? Differential. Okay. All right. So they went ahead and scoped the patient and then took a biopsy, and it came back as poorly differentiated invasive adeno of that gastric mass. So this is my question for you all. How should this esophageal gastric cancer be staged? Gastric cancer, esophageal cancer, or don't know? Doesn't matter. I can go back if you need.
It seems like it's more centered in the stomach, but involving the GE junction.
Yeah, exactly. Right. Yeah, so it's centered. I think it's centered in. I would argue in the G junction. Yeah, and then there's extension into the esophagus, like Arthi said. So sorry, what was your answer, Arthi? What did you think it was?
I think it's a GE junction cancer. There's like some kind of classification where if it's like 1/3 above versus like 2/3 below, it changes the management, but I can't remember the classification.
Right. Yeah, exactly. So that was the point of confusion for a long time up until the most recent AJCC classification. So this is an esophageal gastric cancer. It's at the G junction. So the most recent staging in 2010, which was AJCC edition 7, they harmonized it with gastric cancer staging. This was important because these are usually adenocarcinomas that arise from Barrett's. This is in contrast to upper esophageal cancers, which are usually squamous. So it changes the management because if they have localized adeno of that esophageal gastric region, then they do pre-op chemo first before they resect the patient. So these are the different parts of the esophagus. So we have the upper, middle, and lower esophagus. So the mass is epicentered in the GE junction, within 5 centimeters of the cardia are considered distal esophageal cancers, not stomach cancers. As I mentioned, this was contentious because it was very confusing. People didn't know if esophageal gastric cancer was esophageal or proximal. Or proximal. Oh, I hear an echo.
We're hearing it too.
Let's see. Okay, I'm gonna keep going. Hopefully it won't be too annoying. Oh, okay, it just good. It went away. So it was really confusing for a long time with the 6th edition because people didn't know if it should be categorized as esophageal versus gastric. So another reason that's important is because adeno-CAs of this region have poor prognosis compared to other gastric cancers. So the new edition, it's not new, I mean, it's not that new, it's like 2010. So, but the most recent edition classifies esophageal gastric cancers as esophageal if the epicenter is within the lower thoracic esophagus or at the G junction, or if it's within the 5 centimeters of the stomach, cardia, and the tumor extends into the esophagus. And I think that's what this is. I mean, feel free to disagree with me. Because originally I thought this was a stomach cancer, so I actually created a PowerPoint on stomach cancer, and then I looked up the esophageal gastric, and it was not stomach. This is in contrast to stomach cancer, where we don't, if the epicenter is within 5 centimeters of the stomach cardia without extension into the esophagus. In this case, I think we do see involvement of the esophagus, or if the epicenter is more than 5 centimeters from the esophageal gastric junction. So I didn't read the chest abdomen pelvis. I was just following up on that exam, but I would probably classify this as a distal esophageal cancer because it does involve the distal esophagus and it's epicentered in the esophageal gastric junction. Any thoughts?
I'm not sure if you can always tell where the margin of involved tissue is on these cases. So won't they kind of be doing those judgments endoscopically?
Yeah.
I mean,
I feel like, yeah.
We can have an opinion, but I'm not sure if our opinion will always carry the day.
Right. Okay. So what's your opinion? Sorry, go ahead.
Well, I have 2 questions. One is, you said if it's if the epicenter, or it just seems like it's involving also a lot of the stomach, but you're saying the epicenter is not within 5 centimeters, like the epicenter is around the cardia/GE junction because it's going. Yeah, I guess it is centered there. But just in reference to what Steve said, I do think, like, I mean, endoscopy often is the gold standard, but I do find that sometimes the endoscopists even are not, like, they can get disoriented, especially if, for example, the tumor is involving the whole GE junction. They can't even tell where the GE junction is. So in that case, like, they basically encounter tumor and then they're just going through tumor, so they've lost their orientation to say, like, it's centered here or there. Mm-hmm. So then they've come to us to ask us, what we think about it.
I agree, and I would I'm a little bit of a fusspot about terminology, so I don't like the term epicenter because I don't know if everybody agrees what it means. We all know what the word center means, and we all know what the word centered at means, and we know, the point of origin of a tumor means. Tumor margin, I think we all know what it means, but I'm not sure if we all know what epicenter means. So I agree that in this case, the esophagus looks to be involved, and then it also looks like the proximal stomach looks to be involved. It reminds me of a case where I saw a stomach that I thought, and the surgeon thought, was Linitis, and the whole thing, I mean, it was like twice the thickness of this, but it didn't have that layered, striated appearance, so it wasn't like light on the inside, then dark on the outside. It was kind of all dark, and it was actually just gastritis. It was. I don't have that case to show you today. I cases prepared today because we're short-staffed and I've just been doing a million things. But, it reminds me of that case, that's for sure.
I actually think that's a really good point, and I sometimes like use that for my residents. If like in your case where you see that dense enhancement, that is all thickening of the mucosa, so you know that it is a mucosal process and a tumor process. Whereas if you see like a very thin mucosa and then mostly submucosal edema, like dark edema below it, then that's usually gastritis. Because it won't be as enhancing. It's just edema.
So this part is enhancing. That's why we're considering it.
Yeah. And then if you go down right there, for example, if you scroll down a little bit, yep. See right there, like you've got that thick enhancing part. That's all mucosal tumor.
Right, like on the greater curvature, you've got like a centimeter worth of enhancement that's very abnormal. And the case that I'm describing, it was just gastritis. It didn't have that thick layer of enhancement. It really just had a lot of edema in the wall and just not as enhanced a layer on the surface.
Cool. So I think we're all in agreement, right? That this is an esophageal cancer, hopefully. That's all I have. I will pass the torch on to the next person.
I can go next.